Ma'am.
Friends, I welcome you all for the CME on this beautiful Sunday morning on behalf of Seaward Medical Association, Bombay Medical Union and Wockhardt Hospital. We have eminent speakers today who are very popular, and they are going to enlighten us on diabetic management and advancement in the management. So it should be a very interesting topic because we know so much about diabetes and we know so little. So we should know how to manage it in this century and remove that tag from the diabetic capital of the world. We should all start working on that. So I would invite Dr. Shah to introduce today's speakers. Thank you.
Hello everyone, very good morning. Today I'm talking on behalf of the Seaward Medical Association. And
good morning everyone. My name is Dr. Pranav Kohli. I am a consultant endocrinologist at Wockhardt Hospital, recently joined. I welcome you on behalf of Wockhardt Hospital.
So the first lecture of the day is going to be given by Dr. Prashant Makhija. He is a practicing neurologist consultant at Wockhardt Hospital, and he has done his MBBS from GR Medical College, Gwalior. His MD Medicine from SS Medical College, Rewa. He's completed his DM and he's further done his PDF in epilepsy and sleep medicine from Amrita Medical Center. He has special interest in treating patients suffering from epilepsy, sleep medicine, stroke, movement disorder, neuromuscular, and neurobehavioral science. Can I please welcome Dr. Makhija?
Just a quick reminder, we have a 30-minute Q&A session after all the talks are done. So just hold on to your questions. Thank you.
This we can minimize. And I'll keep it here. Okay.
Thank you, sir, for that kind introduction. A very good morning to all of you. So I'm going to speak on approach to a patient with peripheral neuropathy. So although the topic assigned to me is diabetic peripheral neuropathy, but I'll be speaking about, in addition to diabetic peripheral neuropathy in general. Thank you. So it is common to encounter patients presenting with tingling, numbness in neurological practice, but many a times after just describing some symptomatic treatment in the form of pregabalin, gabapentin, we leave the patient at that point of time. But we do not pursue these patients. And as Madam said, with India becoming the diabetes capital of the world, diabetic peripheral neuropathy is one of the commonest neuromuscular disorder we see in clinical neurological practice. So this presentation is an attempt, how do we approach these patients? And many of the patients who look like diabetic peripheral neuropathy may have some other neuropathies also, which are highly treatable. And we should not be missing these patients. So this is what I'm going to discuss in this talk. It's not working. How do we move the slides? Yeah. This way. Is it on? Yeah. So yeah. So during my residency time, I got this opportunity from my teachers to write a chapter on peripheral neuropathy. And this also featured in a very prestigious book, Differential Diagnosis in Neurology. And most of my today's slides are from this book chapter. So this is the outline of my presentation. Before we talk about the approach, we should know what neuropathy is and a bit about its epidemiology. We should also know to recognize the different patterns in peripheral neuropathy based on history and examination, which not only helps us in classification, but also in identifying the underlying etiology. And finally, briefly, I'll talk about a bit about neuropathic pain also, which we commonly encounter in patients with diabetic neuropathy. So we know from our basic understanding of the anatomy, a nerve comprises of a cell body and a peripheral process. So a neuropathy is a disorder involving this cell body or the peripheral processes. A disorder which involves only the cell body is actually not is known as neuronopathy. If it is a motor nerve cell, this is known as motor neuron disease. If it is a sensory cell body, then this is what we call as sensory ganglionopathy. But what we are going to focus on is the peripheral processes which are affected in various diseases, what we commonly call as peripheral neuropathy. So peripheral neuropathy is not same as neuropathy. Neuropathy is the generic term which includes disorder of the cell body plus the peripheral processes. So today we are going to discuss the diseases affecting these peripheral nerve processes, which is commonly affected in diabetes. So what are these peripheral nerves? These peripheral nerves, apart from, we know there are 12 cranial nerves. So apart from the first two cranial nerves, which include optic and olfactory, the rest of the cranial nerves are also included in the peripheral nerves. And apart from that, sensory nerve trunks, motor nerve trunks, and there's something known as autonomic nerves also. So all these combined together constitute the nerve processes which are affected in different diseases. If we look at the epidemiology, peripheral neuropathy is seen in 2.4% of the general population. And as the age increases, the incidence prevalence increases. So in patients who are more than 55 years of age, almost 8% of the individuals are affected by some kind of neuropathy. That's like 8 out of 100. And as I said earlier, it is one of the commonest neuromuscular disorder we see in day-to-day OPD practice. Most common cause being diabetes. But there are certain neuropathies, in spite of exhaustive investigation, we may not be able to reach any underlying etiological diagnosis in about 20% of the cases. And this is a prevalence data from Western countries. We can see at the bottom, diabetic neuropathy has the highest prevalence. So talking about the classification, The neuropathy can be classified based on the pattern of involvement. By pattern of involvement, what we mean is there may be single nerve affected, there may be non-contiguous or continuous involvement of the multiple peripheral nerves. We can also classify neuropathy based on the time course. Some may present very acutely, some may present over a period of time. The type of deficit, whether it is predominantly motor, predominantly sensory, predominantly autonomic, or a combination of these. And based on the underlying pathology. So what we mean by underlying pathologies is in certain peripheral neuropathies, only the myelin sheath is affected, what we call as demyelinating neuropathy. Whereas some neuropathies, particularly in diabetes, the axon is affected, what we call as axonal neuropathy, and which has a relatively poor prognosis. Neuropathies can also be classified based on the fiber size, as we shall see in the subsequent slides. So this figure shows the pattern of presentation. One of the most common presentation of diabetic neuropathy is carpal tunnel syndrome. You must have heard about patients complaining of tingling numbness, particularly the thumb and the index finger involvement. So this is one of the mononeuropathic presentation. Another common presentation is patients coming with a foot drop, wherein the common peroneal nerve is affected. Another common presentation is patient complaining of tingling and numbness in the anterolateral aspect of thigh, what we call as meralgia paresthetica, particularly common in obese diabetic individuals. So this pattern is mononeuropathy. What we mean by mononeuropathy multiplex is there is sequential involvement of peripheral nerves which are not linked. So one may have a involvement of the median nerve, and few days later he or she may have involvement of the common peroneal nerve. Subsequently, he or she may have involvement of the ulnar nerve. This is what we see apart from in diabetes in certain autoimmune disorders. And the most common presentation which we see in diabetic neuropathy is symmetric length dependent peripheral neuropathy. What we mean by length dependent is usually in diabetic neuropathy, the longer fibers are initially affected. So patient may start complaining of tingling numbness initially in the feet, which then progresses up to the calves. By that time, they start having tingling and numbness in the hands also. So this symmetrical involvement of neurons in length dependent fashion is known as symmetric polyneuropathy. And this is the most common pattern which we see in diabetes patient. And apart from diabetes, it can be seen in certain other metabolic disorders like thyroid disease, and also in exposure to certain toxic substances. One of the common drugs which causes similar pattern is metronidazole, which was commonly used in patients with amoebic abscess. Apart from this pattern, there are certain other patterns also. Sometimes there can be involvement of plexuses. So we know there are two important plexuses in the body. One is the brachial plexus, which supplies the upper extremity and the shoulder, and another is the lumbosacral plexus, which are also commonly involved in diabetic neuropathy. So in such cases, the presentation is asymmetrical, combination of motor and sensory, and it is often quite painful in diabetes patients, and very disabling pain can occur in such cases. Apart from this, diabetes, there are certain other causes of involvement of plexus. One is trauma, another is in certain metastatic disease, plexus are also often involved. Another common presentation is radiculopathy, wherein the pain and sensory loss is in the distribution of peripheral nerve root. Like somebody complaining of a pain which starts from the back of the hand and elbow and particularly involves the middle finger. So we know this distribution is of a C7 nerve root. Similarly, somebody starting with a backache which radiates to the sole of the feet. This is S1 radiculopathy, what we also call as sciatica. It is because of the compression of the S1 nerve root. So the second type of classification is based on the time course. So some neuropathies present acutely within 4 weeks, as we see in GBS and certain toxic exposure like in arsenic. Some have subacute presentation, which we commonly see in nutritional deficiency states like B12 deficiency, thiamine deficiency. Then some are chronic, like what we see in certain autoimmune neuropathies, chronic inflammatory demyelinating polyradiculoneuropathy, CIDP, which commonly presents over a duration of more than 8 weeks. So this is how, based on the time course, we can also identify what could be the possible etiology. Then based on the type of deficit, some are predominantly of pure sensory, like B6. So commonly we prescribe multivitamin, but we should also be aware that certain excess vitamin exposure can also lead to neuropathy. So pyridoxine is, which is commonly prescribed in patients who have TB along with antitubercular medication. So B6 excess can also lead to sensory ganglionopathy. Certain autoimmune neuropathies like associated with Sjogren's or metronidazole can also present with predominantly sensory involvement. Predominantly motor involvement can be seen in exposure to lead, GBS, and mixed involvement is what we see in certain CIDPs. In diabetic patients, it is predominantly sensory along with autonomic. So many patients with diabetes, they will come, apart from the tingling and numbness, they will complain, मेरे पाँव ठंडे हो जाते हैं, कभी पसीना आ जाता है. This is something which we commonly see in diabetic patients, and there's no obvious reason. So these patients, apart from having small fiber involvement, they also have autonomic nerve involvement, which also leads to bloating, constipation. So visceral nerves, which we call as autonomic nerves, once they are affected in diabetes, these kinds of manifestation can be seen. Then another is based on the pathology. As I said earlier, certain neuropathies predominantly affect the axon, which leads to more severe neuropathy, and the prognosis is relatively poor in these patients. Whereas if the nerve sheath is affected, what we call as the myelin sheath, which is covering the nerve, then these are demyelinating neuropathies. They predominantly present, apart from the paresthesia, also weakness in not only distal muscle, but also in proximal muscles. They usually have a acute to subacute growth, and the prognosis is relatively better in these patients. Then coming to the based on the fiber size. So there are three main types of fibers based on the size: A, B, and C. So rather it is A alpha, beta, and then C. So the A alpha and beta fibers, they are the large fibers, and these are the ones which are mostly myelinated. So these are the patients who present with more of sensory loss rather than paresthesia. They will present with more of numbness. They may also present with altered sensation in the feet, in the form of some patients, they complain of as if when they are walking bare feet, they feel like they are not walking on something hard. They are walking something soft like cotton wool. This is something which we see in patients who have large fiber involvement, and they are the one who have more weakness of the limbs. They will complain of slippage of slippers from the feet. They will complain of difficulty in getting up from the sitting or squatting position. Where patients who have small fiber involvement, they are the one who will complain of more of positive sensory symptoms in the form of burning, pricking sensation, and they are the one who will also have more of autonomic manifestation in the form of hot and cold sensation involving the feet, or more of bloating and constipation. Now that we know what neuropathy is, what are the various etiologies, what is the various classification, how do we evaluate these patients? So as we do in basic examination, any kind of examination, we take the history, we do the examination, then we come to the investigation. So we will start with the history. A patient with peripheral neuropathy, they can have motor, sensory, and autonomic manifestation, as I said earlier. So what could be the motor symptom? The positive symptoms can be for cramps. They may also complain of twitching of muscles. They may complain of myokemia, which is more of a widespread twitching. It is like a rippling of the muscle. What we mean by negative symptoms is they may complain of weakness of the limbs. And if the neuropathy is long-standing, this can lead to wasting of the muscle. So diabetic neuropathy or symmetrical polyneuropathy in general, it leads to wasting of the distal muscles. What could be the sensory symptom? The positive sensory symptoms can be form of burning or lancinating pain. They can complain of tingling. Another important symptom is allodynia or hyperalgesia. What we mean by allodynia is in patients with, particularly with small fiber neuropathy, they may complain of pain on touching even a non-painful stimulus. Like they become very hypersensitive. Even if the cloth is touching, their distal part, they may complain, I am not even able to tolerate that sensation of touch of a cloth also. So that is known as allodynia, a non-painful stimulus leading to pain sensation. What we mean by hyperalgesia is a relatively less painful stimulus leads to more kind of pain. This is one of the positive sensory symptoms of peripheral neuropathy. The negative symptoms can be in the form of sensory loss. It can also be in the form of gait problems. So gait problems can not only occur because of the muscle weakness, but or because of the cerebral involvement. Sometimes if the large fibers, particularly those carry the posterior column sensation, vibration and joint position, because that vibration and joint position is affected, their gait can be affected, which worsens towards the evening or dark. The autonomic manifestation, as I said earlier, can be bloating sensation. Lot of diabetic patients who have prolonged diabetes, they complain of frequent belching, flatulence. They may also complain of alternate constipation and diarrhea. Urinary, some of the manifestation of autonomic involvement. So apart from the symptom, we should inquire also regarding what is their day-to-day activities affected. Like patients with peripheral neuropathy, with distal muscle involvement, they may find it difficult to break chapatis. They may even difficult to find opening the cap of the bottle or turning the keys. Those who have a proximal muscle walls. So this suggests involvement of the proximal muscle. And we should also take details regarding how was the onset, whether it was acute, subacute, chronic, as I said earlier, and how did it progress, whether it is static, progressive. This can help us in the classification, which subsequently guides us regarding the etiology. We should also take certain personal and social history, like they have particular dietary habits. Like we all know, B12 deficiency is commonly seen in patients who are strict vegetarians. Another is alcoholic patients frequently have thiamine deficiency. So these are some of the personal history which should be inquiring from the patient. And in the medical history, if they have associated comorbidity, diabetes, of course, apart from that, connective can lead to, which we'll be talking about, can lead to nutritional deficiency. If they have underwent any orthopedic procedures, like some procedure for the wrist or the leg, it can lead to entrapment of the nerves. So frequently wrist surgeries can lead to median neuropathy, carpal tunnel, or surgeries done around the knee can lead to foot drop, common peroneal neuropathy. And as I said earlier, if somebody is taking some kind of medication, chemotherapeutic agents, we all know, can lead to patients with malignancy, can lead to peripheral neuropathy. Excess intake of pyridoxine can also lead to this. We should be very aware, which we commonly see as a neurologist, but this is often overlooked. Excess pyridoxine can lead to sensory ganglionopathy, which is a very severe kind of neuropathy. These patients, they present with an ataxic gait. A positive family history can suggest hereditary neuropathy. Coming to the examination, first we talk about the general examination. So if there are frequent variation in blood pressure and pulse, this suggests autonomic involvement, particularly if it is in relation to the posture. If there are certain rashes, oral ulceration, this can we can think of certain connective tissue disorder like Behçet's. Dryness of the eyes and mouth can suggest sarcoidosis. Skeletal deformities can suggest inherited neuropathies. And enlargement of the nerves, there are two common causes. Leprosy, which we used to see previously, now hardly we come across, can lead to thickening of the nerves. Similarly, CIDP is now a frequent cause of thickening of the nerves. So if somebody is presenting with peripheral neuropathy, the clinical presentation is all like that. Always check for the thickening of nerves, wherein you can check the greater auricular, the ulnar, and the common peroneal. These are the three common nerves which are commonly thickened. And how do we differentiate neuropathy from myopathy? So in general, neuropathies, they lead to distal weakness, whereas myopathies, they lead to proximal weakness. The predominant muscles which are involved are in the legs, they are the toe flexors and extensor. In the hand, they are again the finger extensors and flexors. We can even make the patient walk on heel and toe. So patients who have distal symmetrical polyneuropathy, they would find it difficult to walk on heel and toes. You can ask them to walk on heel and subsequent toes. This can pick up the subtle peripheral neuropathy, which should always be done in patients who come for regular checkup for diabetes. Also, patients who have foot drop, they can present with a high stepping gait, and wide base gait we can see in patients who have sensory ataxia. We should always keep the approach in mind while evaluating the patients with peripheral neuropathy, and we should have some idea about the peripheral nerve anatomy also. Like patients who have a radiculopathy, they will have a distribution of sensory impairment and motor weakness in the root distribution. So we can also have some idea from the examination which kind of fiber is affected. Like if somebody having impairment of the sensation, which is carried by a combination of small and large fibers tested by monofilament, we can say this is because of the involvement of both small and large fibers. If somebody is having particularly small fiber involvement, there will be impairment of the pinprick and temperature. But if there's impairment of the vibration sensation, this suggests large fiber involvement. So how do we go about testing these patients? So there have been certain practice parameters which are published by the American Academy of Neurology. Certain screening tests should always be done in patients with peripheral neuropathy. So these are the first sentence shows that these are the common tests which we should do in all patients with peripheral neuropathy, but particularly fasting blood glucose, B12, and electrophoresis, particularly in elderly patients. And electrophoresis should always be immunofixation method, not the capillary. So always write serum, protein, electrophoresis, immunofixation method, which can be seen in patients who have neuropathy associated with monoclonal gammopathy. It is also seen in patients who have particularly small fiber neuropathy. Their sugar is okay, their HbA1c is okay. The glucose tolerance test can pick up these patients. And particularly patients who have large fiber neuropathy, many times we see B12 to hamara normal hai, 350 something, 250 something, even though it is in the range. So range is like 190 to 900 picogram per ml. But if the patient is symptomatic, and if the levels are of B12 are less than 400, always supplement them. Don't worry about the values. B12 is anyways a water soluble vitamin. So excess will not lead to problem, but deficiency can easily be corrected. So in somebody who's having neuropathy, B12 is less than 4, please supplement them, and preferably by injectable method. Because if you really want to pursue whether this patient is B12 deficient or not, we have to do certain advanced tests like methyl malonic acid, homocysteine, which is costly. This can be abnormal even in patients who have B12 being deficient and having symptoms of neuropathy, even though the B12 is within the range. And as I said earlier, immunofixation method of electrophoresis is more sensitive. Certain special tests can be done in suspected cases like connective tissue disorder, patients with paraneoplastic etiology. We can even go for a PET scan, and those who have autonomic involvement, we can order for a skin biopsy. In patients who have undergone bariatric surgery, we can check for vitamin E levels and copper levels. And we also require CSF studies in certain autoimmune neuropathies. So coming to the electrophysiology, we often order for nerve conduction tests in these patients. So nerve conduction test, what it does is, apart from giving us an objective idea of the neuropathy, it tells us about the severity, the distribution, and whether it is relatively motor or sensory, which can tell us about the etiology. And it also helps in differentiating whether the underlying pathology is axonal or demyelinating. So just look at the first 3 points of a demyelinating neuropathy. In demyelinating neuropathy, the latency is prolonged, amplitude is normal, and velocity is slow. These are the 3 pointers which suggest in a nerve conduction test that the patient is having predominantly demyelinating neuropathy. But if the velocity and latency is normal, amplitude is down, it is axonal. The last slide about the peripheral neuropathic pain. So neuropathic pain is pain in relation to the central or peripheral nerve lesion. What are the various characteristics of these pains? They come with shock-like sensation, which is paroxysmal. They may also complain of burning, which is persistent. They may have pins and needles sensation, or sometimes hot and cold sensation. In addition, as I said, they may also have allodynia, which is a non-painful stimulus appears painful to them, or hyperalgesia. that is a less painful stimulus appears more painful. So whenever we are approaching any patient with peripheral neuropathy, we should, in addition to providing the symptomatic treatment, also look for underlying conditions which are leading to this neuropathy, be it B12 deficiency or uncontrolled sugar, and try to manage them symptomatically. So this is the list of medication which we use in patients with neuropathic pain. It is mainly the first line medication which are relatively useful. To be honest, there is no very good treatment of neuropathic pain, which can sometimes be very disabling in these patients. There have been certain trials of certain medicine, but they have been not that fruitful. So main medication which we use are tricyclics and gabapentinoids. And second line, we can also look for sodium channel blockers. The local preparation, sometimes some companies manufacture these gabapentinoid creams also, but to be honest, they are not that useful. They hardly give any benefit to the patient. So to summarize, while evaluating a patient with peripheral neuropathy, we should have a focused approach based on detailed history and clinical examination. The electrophysiological studies and blood investigation can help us in pinpointing the specific etiology. And while choosing the drug, we should take into consideration the clinical profile, associated comorbidities, and cost also. I would like to end here. Thank you.
Thank you, Dr. Makhija, for the wonderful talk. Our next speaker is Dr. Raman Goel. As many of you all may be knowing, Dr. Goel is a pioneering surgeon in laparoscopic surgeries. He's trained hundreds of surgeons over the years, as he was the professor of surgery at Grant Medical College from 1994 to 2010. He has been performing bariatric surgery since 2001, and he's the founding member of the Obesity Surgery Society of India and past president of All India Association for Advancing Research in Obesity and Indian Association of Gastrointestinal Endosurgeons. Sir has been conferred fellowships by 3 prestigious surgical societies worldwide: the Royal College of Surgeons from UK, Obesity Surgery Society of India, and the American Society of Metabolic and Bariatric Surgeons. He also has been serving as the founding editor of the Journal of Bariatric Surgery and is also currently involved with editorial work on multiple other surgical journals. And lastly, Dr. Raman Goel has been honored as the first Indian Surgeon of Excellence in Bariatric and Metabolic Surgery by the Surgical Review Corporation of USA. He has 2 talks today, this morning. The first one is surgery as an effective therapeutic option for diabetes mellitus. So that's what he's going to talk about right now. If you can.
Good morning. Sarah is fixing it up. This particular presentation has come out of a necessity because one of the videos that Wockhardt Hospital created for treatment of diabetes for some funny reason became gone viral. And we suddenly started having hundreds of calls from patients, and those patients also approached you as physicians that, is this true? A lot of people, you're fake, and said, how come doctors make such claim? So what I'm going to talk today, after such a wonderful talk, clinical talk by Prashant, is more of a concept explanation. This is something which bariatric surgeons knew for a long time, but got approved recently, and that's why there is a lot of confusion whether this is true, whether Raman Goel is fake, or what I'm claiming is not correct. So let's go with this. Can we have it on? Okay. So, is surgery the most effective therapy for diabetes? Let me put a disclaimer. I'm not saying is it the most effective therapy. Literature that's available to us, I'll share it with you. I advise Ethicon Endosurgery and also Novo Nordisk on some related issues, but there's no financial involvement for this particular presentation. And as told that I'm doing bariatric surgery from 2001 and only bariatric surgery from 2011. I stopped doing general surgeries. And in today's time, I'm doing about 70% Roux-en-Y gastric bypass, about 10% revisional bariatric surgeries, which patients referred from different places, and a small number of other procedures. I'll start with a patient we operated recently in December. This lady who is 50-year-old, about 87 kgs, she's not in hundreds of kgs, diabetic for 6 years, hypoglycemics and insulin. And still her fasting sugar, she's a healthcare worker in Mumbai. Her around 240, PP around 450, and HbA1c was 50. Frankly, this is the first time I saw somebody with HbA1c 50 and I was scared. I said, how come you're walking around? And I asked her to see Dr. Hani Savla, and she was put on a more advanced medication on a regular insulin to bring down her sugars to prepare for surgery. So this patient I'll refer at the end, but just to give you an idea, a patient with just 87 kgs and HbA1c 50 came to us. And she is definitely not alone. Literature says that almost 78% of Indian diabetics remain uncontrolled despite whatever you do. Worldwide, I believe it's between 55 to 56%. So, and then when they are uncontrolled, they are likely to have more complications. That's what you know better than me. Then why we are talking about surgery for diabetes? Before I go ahead, let me explain one terminology. So in 2009, there was a meeting held in Europe to define remission of diabetes, which has never been done in last thousands of years. It was basically done because surgeons started claiming that we can give remission of diabetes. So physicians got together along with surgeons and they defined this. And this got published in Diabetes Care, that if HbA1c is less than 6.5 for a year, then it can be called partial remission. If HbA1c is less than 6 for 1 year, it will be called complete remission. The condition is that patient should not be on any diabetes medication. So this is a very tight regime or tight definition. After surgery, no medicine for 1 year, and still HbA1c should be less than 6.5 or less than 6. Obviously, this is not possible with medicine. Because if you control it with medicine and then you don't give medicine for 1 year, then obviously patient will have a higher HbA1c. So this only applies for surgery. But the difference is, and this is where I am writing an editorial right now on this, that this is not matching apple to apple. When you treat diabetes, you treat to control. But when we are told to treat diabetes, we are told to bring them in remission. Okay, the cure was not used because we said when this meeting was held in Europe that diabetes, like a cancer, cannot be cured. You can only call it remission, in remission. So what happens is that even though I can claim as a surgeon that I can give control to 80% patients, but when it comes to remission, it is like 35% patients. So the target of surgery is not to stop medicine. Target is to give them better glycemic control, like what you do. Okay. So on that ground, so the difference between remission and control is remission is without medication, control is control. So to achieve better glycemic control and to help or avoid diabetes-related complications. So there are multiple publications. This publication in 2004, which was the first publication on this series, which says that within a year after surgery, 80% patients will have normal blood sugar without medicine after bariatric surgery. There is another long-term follow-up publication which says after 10 years, one out of the 3 patients who had surgery for diabetes will not need medicine. They have called it remission. What about other 64% patients? They will also be in control. But since the remission definition came into kick, it said that only 36% will be off medicine after 10 years. And then there are many other publications which are long-term follow-up publications. So this particular publication says that risk of myocardial infarction reduces from 1.8% to 0.3%. That means 84% reduction in myocardial infarction, 75% reduction of brain strokes related to diabetes, 79% reduction in diabetes-related deaths, 66% reduction in blindness, 86% reduction in amputations, and 87% reduction in heart failures. So it's not a question of just glycemic control or discontinuation of medicine. We are now talking of whether we can help reduce the complications in long run. And there are multiple publications. I'll just show you one of them. This is something that has been used by physicians, that if you have a remission for 1 year, the microvascular disease will reduce by about 19%. We are talking of 36% patients remaining in remission for 10 years. So we just need to multiply and see how much microvascular complications are likely to reduce. And with all the physicians sitting from Wockhardt Hospital, we are starting a study to assess impact of this surgery on diabetic nephropathy. So it's a prospective study starting within a month's time. We already have ethical committee approval for that. Then there are other benefits which are known to happen with any bariatric surgery in terms of control of blood pressure, reduction of triglyceride, and myocardial infarction. So those benefits continue because we are ultimately talking about bariatric surgery. There is no new surgery that we are talking. But there are other studies which shows that there is a 40% reduction in all-cause mortality and 56% reduction in mortality due to coronary artery disease. And another long-term study which says that diabetic patients, if they undergo surgery, they are likely to live longer by about 9 years. Now, which other treatment or surgery gives an extension of life by 9 years? The only other surgery that we know is a CABG, where the lifespan is about 5 to 6 years. So this is the kind of results which are there. So if it is so effective, why it is not standard of care? Why people are questioning us that why you are putting out this video? And so let me show you why this has become a standard of care and you should see that evidence. We published our own data at Wockhardt Hospital of follow-up for bariatric patients, where we said after 3 years, 80% patients of sleep will not need medicine. They are still not on my diabetes medication. And bypass patient, 92% of them, nearly 92%, will not need medication even after 3 years. After 5 years, we followed these sleep patients. 64% of them were still not needing medicine. Okay, and we followed them at 7 years, and all these are separately published data, where we said that because by the time this remission definition came, we said 32% at 7 years are still in remission. They don't need medicine. Partial remission, that means another, as you can see, below 6.5 and another 22%. That means almost 55% patients even 7 years after surgery are not needing medication for diabetes. And those patients who are not in remission but that have got HbA1c below 6.5 with medicine are another 13%. That means 68% patients, even 7 years after surgery, are maintaining HbA1c below 6.5 in our own practice, in our own experience. This is a study from US where they said that within 1 year that thing has come, few $1 million of saving in use of medication after bariatric surgery or after metabolic surgery, whatever you call it. So these are the patient. The green bars shows that these patients don't need medicines. All right. So this is before surgery, and this is after surgery. So based on this, somewhere in 2011, International Diabetes Federation came out with this advisory or white paper, which says that surgery should be offered as a treatment, alternative treatment option to patients who are not well controlled. 2011, nothing moved after that. 2021, the American Diabetes Association came out with this guideline saying that same thing they repeated, that this can be offered between 30 to 35 BMI patients who are not well controlled. And both these associations said, these are physicians association, that for Asians and some other ethnicities like Africans, this should be reduced by 2.5 BMI. That means 27.5 BMI, this can be offered. Still, we have not started surgeries on these. But in 2022, the guidelines changed, surgical guidelines changed. 30 years after when they were formed first time by NIH in 1991. Now the new guidelines says, which came in December 22, that I can offer a bariatric or metabolic surgery at 35 BMI, even in absence of comorbidity, 30 BMI in presence of comorbidity, and 27.5 BMI for Asians whose sugars are not well controlled with medication. So this is the current status based on which we started operating patients. And not only that, in UK, the NICE guidelines came where they said that if there is a person of Asian origin in UK, NHS, and if they have a diabetes for less than 10 years, NHS will offer this surgery free of cost to them. So it's not something that came out of nowhere here. This is even a British guidelines, and these people can have surgery there. Few important statements before I go. Number one is this is temporary trial from Cleveland Clinic, which says that the benefit of the surgery is similar, whether it's a patient BMI, higher BMI or lower BMI. Because people say this surgery benefit comes because you have lost weight, but it is not that, it is even lower BMI. It is also weight loss independent. So there are other studies which says glucose control is not related to amount of weight loss. The last statement is not very strong. This is a very small study, so I must tell you it's a qualified statement, that will the patient maintain blood sugar if the weight regain happens? This particular study said yes, but they are not, it's a very small group of patients and it's not very strong, but we will know as we cross the bridge in times to come. How this surgery is done, you all know it. I'm sure you have been, many surgeons have taken lectures, the same sleeve gastrectomy or one of the type of gastric bypass. So now we don't call them bariatric surgery, we call them bariatric metabolic surgery, BMS, because the effect is the same. These surgeries typically nowadays take, there's laparoscopic surgery, takes about 40 minutes to 1 hour. Blood loss is usually less than 50 ml, and hospital stays less than around 48 hours. How does diabetes gets resolved? Because the food is rapidly delivered in distal bowel from where GLP-1 is secreted, and GLP-1 improves insulin sensitivity. So patients have restoration of acute insulin response, which gets lost in type 2 diabetic patient. They have enhanced insulin secretion. The GLP-1 works on beta cell, improves beta cell sensitivity to glucose. And also it's not established, but it's probably that they also increase number of pancreatic beta cells. There are other mechanisms like enhanced biliary secretion or calorie restriction, but primary mechanism is GLP-1. And these are weight loss independent mechanisms. They reduce hepatic glucose production, obviously there is a calorie restriction and there are multiple mechanisms by which this works to control diabetes. What we have learned in last 23 years that I am doing bariatric surgery is that if you want the patient want to maintain diabetes or glycemic control in long term, they must continue to have the diabetic diet. Just because their sugars are under control does not mean, it doesn't give them license to eat sweets every day. So they follow everything that is told by you to or your nutritionist to your patients. They must exercise regularly and they must check their blood sugar regularly. In one of the studies we found after surgery that many patients became uncontrolled diabetic because they thought they have cured their diabetes and they don't check it. So it's a good idea to keep on checking their HbA1c at least 3 months or 6 months. Over a period of time, surgery has become much safer. Now we know that the perioperative mortality of bariatric metabolic surgery is less than that of laparoscopic cholecystomy. So you get gallbladders done routinely, but with getting a bariatric surgery, there is a hesitation about the safety, but the data says otherwise. And the risk of death is much less after surgery versus those who were denied surgery, who never opted for surgery. And then it's not a new surgery. I mean, the concept of using surgery for diabetes is new, but we are doing the same surgery for decades now. So the surgically is not a new surgery. When it should be done as a physician, 27.5 BMI, that means they should be about 8-9 kgs overweight. HbA1c at the moment we are keeping it 7 because the guidelines don't say what is uncontrolled diabetes. So we are using 7, but it's an open guess. And they should have fasting C-peptide at least 1. Higher the C-peptide, higher the resolution of after surgery. So those patients who come early to us, let's say in first 5 years, they will probably never need medicine in life. Those who come between first 10 years, between 5 to 10 years, 80% of them may not need medicine. So that means 80% will remain. Those who are coming after 10 years will still have control, but they may not go off completely of medicine. So as I said, it's about treating the diabetes. It is of no use in type 1 diabetes. LADA and MODI are to be excluded. So we always get antibodies done. And those patients who come to us in first 30 years of their life with diabetes, we also get some genetic tests done to exclude MODI type of diabetes. Fortunately, because bariatric metabolic surgery got covered by insurance, but the guidelines are still old. So those who are coming with above 35 BMI, insurance covers it. Below 35 BMI is not covering. We are representing to insurance, the IRDA. Hopefully, next 3 to 5 years, we should get approval for new guidelines, but it will come through. The cherry on the pudding is in knowing what happened to our index patient. That lady I showed you initially. Her fasting, the blue line is the fasting sugar. This is postprandial sugar. This is at 1 week, 1 month, and 3 months. It dropped down. Her HbA1c surprisingly within a month came down from 15 to 10.5, and at 3.3 months it is 7.4. And this is when she has gone off these 7 medicines. She is only on metformin at the moment. So medicines reduced from 7 to 1, and HbA1c reduced from 15 to 7.4. I just use this particular patient to show you the drastic change. Few other patients who dare to get this surgery done early with us from December onwards, they all are showing similar trend. Reduction on their sugar levels and their HbA1c levels. Each of them is a patient, and these are their preoperative values, and these are the values at 1 month and 3 months. And like this particular lady is at 5.8 HbA1c, and all of them are now between 5 to 7. And this is an average. So if you do it at 6 months, this should come down further. So friends, diabetes surgery is just an additional tool. It's like cardiology or oncology, where surgeries are also used, medicines are also used. Medicine discontinuation should not be even discussed with the patient, because when you get a CABG done, you still continue them on antihypertensive and dyslipidemic medicine. So holding back or denying a patient a surgery when it's indicated is not to be suggested. So take-home messages are: it's possible to give long-term blood sugar control. Higher remission rates are seen in early diabetics. So, the NICE guideline, British guidelines say that in first 10 years, the surgery will be given by NHS for a reason, because the results are better seen in those patients. So holding back surgery that will offer it after they are on insulin for 5 years and all that is actually counterproductive. So what I practice in my own clinic is, if somebody comes and says, my father had a cardiac episode at 45 years of age after diabetes, those who have early renal failure after diabetes in their families, probably they have more aggressive diabetes. While those who are on metformin for 20 years and are maintaining sugars around 7.5, I will say you don't need anything. You should be happy that you have a diabetes like this. Diabetes complications is what we are trying to, every one of us are looking at, and reduction of heart attack, brain strokes, and reduced deaths. So thank you so much. I'll be very happy to take questions at the end of the
Thank you, Dr. Goel. A nice lecture. And for the next lecture, I would like to invite Dr. Hani Savla from Wockhardt Hospital. She's a specialist in internal medicine. She is an active teaching experience. So she gives regular lectures for physicians and postgraduate residents. She's in the faculty of diabetes education, where they've made a series of education programs for physicians and residents. She's an investigator at the national level for campaign for assessing random sugars for more than 1 million individuals. She has certified training from BMG and Royal College of Physicians for diabetes in special situations and comorbidities. And she's an advisor to various organizations for metabolic and diabetic drugs and the technological platforms. Please, Dr. Savla.
Hello, everyone. Thank you so much for the kind introduction, Doctor. And after the two stalwarts speak from Wockhardt, I'm the third one. I hope I prove as good as them. They are my mentors. So now I'm going to specifically talk about semaglutide, because right now we're talking more about diabesity, that is diabetes plus obesity. So I would like to first start with that, how did drug come in the picture? So in prehistoric times, the genotypes which favored fat storage were given survival benefit, because those individuals who could not store fat could not survive. And that is why the genotype which favored fat storage, those individuals survived. But then when this became a disease, eventually there were the calorie dense foods which came in the market. There were junk foods which were easily available. The financial status of the people improved with good quality of food available as well as quantity of food available. The portion size increased, and eventually people started to have more and more fat storage, and this turned into overweight and obesity. By around 18th century, it was recognized as a disease, overweight and obesity. And then today, we are here when we are talking about surgeries to treat it, as well as medicines which are specially going to target this as a disease. So now when we treat diabetes, it is not just like the old days, we would like to target diabetes in a multicentric approach where we will target the obesity as well as diabetes. So that is why there was need for a medicine which could target both the things. As we can see, the statistics which support that 1 in 10 adults have got type 2 diabetes and 4 in 10 adults are obese. And nearly 9 in 10 out of type 2 diabetic patients are going to be obese and overweight. So we must have seen in our clinics also, most of the times the type 2 diabetic patients are either falling in the category of overweight or in obesity. And all this surprisingly gives you more than 7 times increased risk of mortality as compared to other individuals. That is why it is very necessary that we address not just obesity, but we address right from the beginning when we start the treatment, when we treatment naive patients, we target diabetes, we target obesity, and we target the risk for cardiovascular disease. So there should be a drug which can address all these needs at a time. Why do we talk so much about it? Because as the weight progresses and as they progress towards the higher classes of obesity, the burden, financial burden on the healthcare also increases and the health hazard increases. And that is why there came a need to revise the management of diabetes, where we talk more of an upstream, more of a multi-centric approach rather than just glucose-centric. So now we are not just going to look at lowering down the blood glucose levels, but we are going to target the weight also. And what is an additional advantage? When you have this weight-centric approach, you are actually not just treating diabetes and obesity, you are preventing NASH, you are preventing OSA, you are preventing osteoarthritis, and you are preventing dyslipidemias. But when you just go for glucose lowering drugs, you are just reducing the blood sugar and the other things are not addressed. And that is not what modern medicine looks at. So that where we have weight loss, we are actually going to correct the underlying mechanism. So why weight loss is important? Because it disrupts the underlying pathophysiology, it promotes the glycemic control and even improves the cardiometabolic factors. I'll come shortly to what are the cardiometabolic factors that will be improved. But eventually, the micro and the macrovascular complications of diabetes will improve if we target the basic pathophysiology. It has been seen in the Look Ahead trial also that when the patients they had weight loss, their HbA1cs were significantly reduced, not just with medicine but with weight loss also. Almost 2.5 to 5% of weight loss was associated to bringing HbA1c to less than 6.5. And if you have 5 to 10% of weight loss, you're further going to reduce it by 0.5% every time. So it helps you to do really well from your glucose point of view, from your lipid profile point of view, as well as from your weight point of view. So why do we say that once we have weight loss, cardiovascular parameters improve? Because there is a pleiotropic effect, that is the blood pressure comes down, the triglycerides come down, HDL improves, and LDL also comes down. And that is what we want to target for any patient who has especially got, as I said, risk of heart disease in the family. So these are going to be the ideal candidates for whom we want to promote weight loss in addition to just treating diabetes. So, and one thing which Sir spoke very nicely about remission. Till last 10 years before, we were not talking so much about remission because we didn't have so many options. But now we are in an era where, not just human platforms, not just doctors, even ultra-human platforms like Twin and Fitterfly and Healthify are also talking about remission, because remission is possible now. And we definitely require a weight loss of more than 15 kgs to bring about remission. And that can be done when this is targeted right from the beginning, when we initiate the treatment. Now, talking about we know now the weight loss has got, we have registered in our mind that weight loss has definite advantage for controlling diabetes. But what are the available options for weight management? So, moment a patient comes in a clinic and we talk about options of weight management, the first thing we always tell them is diet and lifestyle. But let me tell you that, as it was very nicely put by one of my mentors, that if diet and lifestyle was a drug, and it went to an FDA for approval, it will not even get an approval. Why? Because there is not even 5% sustainable weight loss that is achieved with diet and lifestyle. We have been practicing this since centuries, and it has been seen that very nicely that we may lose weight with the diet initially, but then to sustain it and to prevent regain is the biggest challenge. So there were trials which supported this. As you can see this, there were various trials in which the weight dramatically reduced with this diet changes. But as the diet changes were modified or stopped, there were, you can see, multiple trials which even showed weight loss, which showed weight gain, and many trials where there was no weight loss or not even significant weight loss happening. So definitely diet is not going to help you to achieve more than 15 kgs of weight loss and to have actual remission of diabetes. So what is the reason behind this? The reason is that diet is like a famine. It actually increases your appetite stimulating hormones like ghrelin, because of which you start feeling more hungry, you start burning less calories, rest time increases, and so does the weight circumference. And there is increase in the brain response to have more tasty foods, more homeostatic and rewarding regions want more and more of tasty food. And that is where the weight regain occurs. So that is why diet has not been proved to be very useful for achieving this weight loss. Then second thing was diet with lifestyle. So in lifestyle, the statistics say that 8 out of 10 patients require additional interventions apart from lifestyle to achieve their weight loss. And even if they were on that same lifestyle intervention for more than 5 years, they started having weight gain. And that is why, again, this was not possible to give you a sustainable weight loss and remission. That is why diet and lifestyle definitely are required, but they are not sufficient to give you a weight loss and a good sugar control. And that is where there was a need for pharmacological therapies for having weight loss. And these therapies have, as you can see in the graph here, the dark blue color, which you can see that with pharmacological therapies, even after the therapies were stopped, there was a sustainable weight, but there was no regain. But whereas in the other group, where other things, only diet and lifestyle were used, they had a significant regain after the modification were stopped. So definitely pharmacological options are better. So now when we come back to our same thing, diabetes plus obesity, what are the drugs that are available which will help us to achieve this weight loss as well as sugar control? So we have a range of drugs, as you can see in the slide, the drugs which can give weight loss, drugs which are weight neutral, and which can even give weight gain. So let us concentrate on the drugs which can give us weight loss, like SGLT2 inhibitors, metformin, pramlintide, and GLP-1 agonist. So as we talk more about this, why GLP-1 agonists won against other molecules? The simple reason was the weight effect was much higher as compared to others, and the cardiovascular benefits were also higher as compared to the other drugs. Of course, SGLT2 inhibitors were also at par with GLP-1, but if we consider all the effects together at the cardiovascular factors, at the weight, as well as at the risk of hypoglycemia and the efficacy wise, GLP-1 agonists definitely proved superior to them. Highly effective HbA1c reduction, weight reduction which was sustainable, and less risk of hypoglycemia. ADA 23 also published the guidelines where they have now encouraged that if you are having patients who have already got heart failure, CKD, try to do treatment initiation with the drugs which are going to protect your heart. So at those times, ADA also recommends using SGLT2 inhibitors and even GLP-1 agonists. And since now we are looking towards both weight and glucose lowering options, and ADA has also certified that treatment initiation should be such that we are targeting and using drugs which will look after all these things of weight as well as sugar reduction. So central action of GLP-1 agonists, why do they help with weight loss so much? The most important thing is that they indirectly activate the brain region in hypothalamus and the hindbrain, which are involved in appetite regulation. They reduce the energy intake, the craving for the food, and the body weights. They delay the gastric emptying time also, and that is why the satiety is pretty high, because of which the hunger reduces, energy intake reduces, the portion size decreases, the cravings reduce. So indirectly, it actually takes care of your mental health also. It reduces your cravings for the food, and that is how you end up eating less portion and end up doing better from the intake point of view. So diet, lifestyle plus medication, especially GLP-1 agonists, will together reduce the hunger and the portion size and will prevent overeating. So now there was a challenge because we had injectable GLP-1 agonist. So the companies thought that if we get something which is oral, the compliance will always be better. But the challenge here was that these were peptide drugs. And as we all know from our physiology classes, that if a peptide is taken, it is immediately broken down by the acidic pH of the stomach. So now there was a place for some new genetic engineering innovation which could answer this all. And there came semaglutide in the oral form. So out of all the GLP-1 agonists, because of its low molecular weight and longer half-life, semaglutide was chosen to be converted into oral form. It was done with the help of one more molecule called SNAC. So it was attached to SNAC. So what actually happens here is that this molecule called SNAC, as you can see, there are two molecules which go together into our stomach when we take this pill, semaglutide plus SNAC. So advantage of SNAC is it protects the molecule from the acidic pH of stomach, and at the same time helps the absorption in a transcellular way. Between the two cells of the stomach, the semaglutide can directly enter into the systemic circulation, that is into the blood, and the action starts. So because of this new genetic engineering technique which was devised, very nicely a peptide was brought into a pill and it was easily taken, and studies promised weight loss. So all this time we had only injectable which added to the injections which our patient had to take. But then the oral drugs came which could help weight loss, and they had an easy method of taking orally. So it is the only GLP-1 agonist as of date which is in the tablet form, which provides superior HbA1c reduction as well as weight loss. So what did the trial say? So Pioneer trial was done with oral semaglutide, and it said that it proved in the post-hoc analysis that almost if the patient had HbA1c more than 9 at the initiation of treatment, it went down by 2.6%. But this was with 14 mg of oral semaglutide, that it went down to 2.6%. And about weight loss, at the end of 26 weeks, the weight went down by around 50 kg, the 5 kg of weight loss occurred. And the most important thing which I feel is important when we look at weight loss is that we don't want muscle loss in our patients. We want fat loss. And fat loss is easily known through the waist circumference. So even that was one of the endpoint in this trial, that the fat mass loss was more than the lean mass, and the waist circumference also went down by 4.7 centimeters at the end of 26 weeks. So it was well proved that it is not giving you muscle wasting, but it is giving you fat loss. And with this, 1 in 2 patients achieve more than 5% of weight loss, and 1 in 5 patients also achieve more than 10% of weight loss while being on the treatment. Along with that, the other parameters also improved. Lipids improved, systolic blood pressure improved, CRP levels improved. Now, the best part why we support oral semaglutide, because the side effects are only GIT side effects, like it can cause nausea, vomiting, diarrhea, which can be handled with certain changes in the diet and can be improved. So that is why there was a large safety database. It can be used freely in the patients who have chronic kidney disease, even liver impairment. It can be used in those patients who have had episode of hypoglycemia before, because it has got very low episodes of hypoglycemia with semaglutide, and no new or unexpected findings were seen till now. And now recently in Obesity Week, 2-year sustained weight loss data was also presented, and it was seen that oral semaglutide proved good enough to have a sustained weight loss up to 2 years also. Now, since it's a recent drug, now 5 years and 10 years data also should be worth reading at with semaglutide. So now we have a lot of things which have been addressed by semaglutide, but still there will always be some unmet needs. Some patients who will not tolerate, or some patients who will not achieve the weight loss which we are looking at. So that is why there are other drugs which are also in the pipeline. There is one more drug which has been approved. It is tirzepatide. It is the first drug which is going to target two receptors. It is going to act on GIP receptor, gastric inhibitory peptide receptor, as well as GLP-1 receptor. So this molecule has been also actually suggested by ADA to be started early wherever it is available for weight loss as well as for sugar control. It has shown up to 15 kgs of weight loss at the end of 68 weeks, which is really worth trying. That is why this drug has been now approved already by FDA, but it is still not available for use. Another drug which is going to be in the pipeline, which is still in the research, yet not approved for weight management, is the combination of Cagri and Sema. So cagrilintide is a drug which is an amylin agonist, and Sema, as I've already told you, both of them have a half-life which extends up to like 180 hours. So they can be given like a once weekly injection. They also promise to give a good amount of weight loss, but it has just completed phase 2 trials, and there are a lot of milestones yet to be achieved to be approved. So looking forward for more and more drugs to help us in weight loss, to help us in controlling diabetes at the same time, because if there is a weight loss, a byproduct will definitely be there of having a good blood sugar management. So I would like to end my talk saying that 9 out of 10 people are obese or overweight, and we have increase in mortality because of this. So it's best that we have a multi-centric upstream approach when we treat our diabetic patients, and let us have no restrictions and start trying these new drugs which are available and which have proved till date to be good and safe for our patients. Thank you so much for your patient listening.
Thank you, Dr. Hani, for a wonderful talk. I'd like to call Dr. Raman Goel for the second part, combination therapy.
Electric shock. Yes. All right, friends. So after Dr. Savla has explained the role of semaglutide in detail, it becomes easier for us, because in bariatric surgery, we have started using more and more of our pharmaceutical agents. So on one side, we are going to do surgeries for diabetes, on other side for bariatric, we are using pharmaceutical agents. Because ultimately, it's how the patient benefits that's important. So this is about Novo Nordisk support to this program. Again, the same case mix. So why this is important that we think of combination therapy, even though we have been doing, because it has been seen that bariatric patients, all of them do not respond uniformly. So each of these dot reflects a patient. So some of them lose weight very well, some of them don't lose, and what you end up seeing in presentation is the median graph. So we show you this, that the average weight loss is this much, but between patient there is a variation or heterogeneity, and that is why we need to individualize the treatment for those patients. And it has been seen that centrally the response to treatment varies, because the various interventions like lifestyle interventions target certain part of the obesity control mechanism, while the medical management controls certain part of obesity management, and bariatric surgery controls certain part of the obesity the circuitry, let's say. So if you use all of them, they will probably control different parts and will have better outcomes. And that is why this is being increasingly felt that we should offer combination therapy to patients to have better weight loss outcomes. Now, it has been seen that when we do we put the patients on a low-calorie diet before surgery, and they lose about 8% of their excess weight. then their overall weight loss improves at 1 year after surgery. So preoperative weight loss helps in better outcome of surgery. It is also seen that if they lose 8% weight, then their hospital stay is shorter. And though on an average the hospital stays 48 hours, but this particular study says that it's shorter. And lifestyle interventions, if they are done before surgery, then it is also published that it leads to avoidance of weight regain in long run. These are very controversial statements, because how come somebody who loses weight 3 years back before surgery will not regain weight 3 years later? But these are the outcomes which have been seen. Now, where can we use these anti-obesity medicines? Or do we use them in preoperative period, post-operative period, or in long term? Now, as far as drugs are concerned, at the moment, semaglutide and orlistat are the only two approved drugs in India. But semaglutide is not available for weight loss. It's available for diabetes management, but the weight loss, the Wegovy, will be available somewhere in 24 and or 25. Because there is so much demand of this drug in Western countries, they are unable to supply to India. That is the reason why it's not available. And so we'll be talking mostly